Good morning, convening the Committee on Health and Homelessness. Welcome to the people here in the room, as well as to members of the public who are joining us, as well as committee members who are joining us by Zoom. Today is Monday, November 6th, 2023, 9 o'clock a.m. We are in conference room 309 of the Hawaii State Capitol. Today's informational briefing is to update the committee and the public on the status, goals, and objectives of the State of Hawaii Department of Human Services Section 1115 demonstration renewal application being submitted to the Centers for Medicare and Medicaid Services. There's a lot of exciting things happening in the MedQuest division of our Department of Human Services. We are very fortunate to have today with us MedQuest Administrator Judy Moore-Peterson, Assistant Division Administrator Meredith R. Nichols, and Health Analytics and Informatics Administrator Ranjani Starr. To the members of the public, this is an informational briefing that is going to cover quite a bit of exciting initiatives going on in the Department of Human Services MedQuest division. This is an opportunity for members of the public, and I want to welcome members of my committee, the Committee on Health and Homelessness. They will be joining us, some by Zoom, some coming in and out. We have a very busy interim session, as I know you're well aware of. To the members of the public, I urge you to stay through the entire briefing. We hope that this is going to take about a 2-hour period. There's a lot of really good information and opportunity for public engagement still in this very important process. So with that, I'm going to turn this over to Ms. Judy Moore-Peterson.
Thank you so much. Really appreciate it. Judy Moore-Peterson, MedQuest Administrator. That's actually also the state Medicaid director. And we are going to do this in 3 different sections. We're going to start off with an overview of MedQuest, as well as an overview of what a section demonstration 1115 section waiver is, and then and the renewal. And we'll cover current waiver initiatives, and then we'll end up with the proposed, some of our proposed new initiatives. But the first thing I'm going to do is I'm actually going to turn it over to Meredith Nichols, who's going to kick us off in our demonstration here. So I'm just going to.
Mahalo, Judy. Mahalo, Cheryl Baladi. Really appreciate the invitation to be here and to share some of what we wanted to talk about here with our 1115 waiver. As always, we like to start with grounding us in MedQuest. Who are we? What is it we're charged to do? For those who may not be aware, who are watching, MedQuest sits under the State of Hawaii Department of Human Services, and we administer the Medicaid program. We provide eligible low-income adults and children access to health coverage through our Quest integration health plans. And Quest is actually an acronym, which is a fun fact for us. So Q, quality care, universal access, efficient utilization, stabilizing costs, and transform healthcare for members. We also have a vision, mission, and values that drive the work we do and the decision-making we do. So the vision for us is the people of Hawaii embrace health and wellness, all of our people, not just our members. And then our mission is to empower Hawaii's residents to improve and sustain well-being by developing, promoting, and administering innovative and high-quality healthcare programs with aloha. And again, I know that we want to really be focused here today on those innovative and high-quality healthcare programs that'll surface as we talk more about this 1115 waiver, and of course, always working with aloha. And then our values, hi'iola. Hi'iola does mean embracing wellness. Hi'iola, to carry that wellness as you would a child. And that acronym is healthy outcomes, integrity, ohana nui, innovation, optimism, leadership, and aloha. All right, so another guiding idea we have here is our Hawaii Ohana Nui hope framework highlights. So again, because we love acronyms, that's, if you hear us talk and have heard us talk in the past about the HOPE framework, now you know. It stands for Hawaii Ohananui Project. One moment. Okay, so this framework serves as a roadmap to achieve the vision of healthy families and healthy communities, and it does drive our Medicaid innovation and delivery system reform in Hawaii, including the Section 1115 demonstration, and we'll talk about in a couple of slides what that means when we say 1115 demonstration waiver. But the innovation framework really does consider the whole person, the whole family, the entire whole community. We look at the social drivers of health, meaning and including health-related social needs, the integration of behavioral health across the continuum, and not seeing behavioral health as somehow a separate goal than our physical health. Building on family and community strengths, so very asset-based, working together with diverse community partners for system transformation, and health equity and addressing health disparities. And we do have that triple goal of better health, better care, and very importantly, sustainable costs. And then some strategies we use to get there: investing in primary care, prevention and health promotion, improving outcomes for high need, high cost individuals, and very importantly, the need to align financial incentives with health outcome goals. And again, as we walk through, you'll see where that's very critical in making changes in what we do. And support for community-driven initiatives. And then our foundational building blocks, we use health information technology to help drive that transformation, increasing workforce capacity and flexibility, and performance measurement and evaluation.
Meredith, if I may interject, for those of us who are watching, this PowerPoint slide will be made public as part of the informational briefing materials, so people don't need to be screenshotting it furiously as they're watching. All of this is public information and will be made available.
Absolutely, thank you so much. And in fact, if you want to follow along, you can go to our MedQuest website and look for that 1115 section, and you'll be able to pull it up and follow along as we go right now. So here it is. What is a Section 1115 demonstration? A Section 1115 demonstration is sometimes called an 1115 waiver, and it's a special authority that allows states to implement new and innovative policies and benefits in their respective Medicaid programs. 1115 demonstrations must be approved by CMS, or the Center for Medicaid and Medicare Services. And they're subject to budget neutrality and evaluations. In this presentation, we will also share some key results from the evaluation of our most recent 1115 demonstration. Let's see. Okay, I should note before we move on that it is, if you want to ground where this 1115 exists, it's under Section 1115 of the Social Security Act. And the Secretary of the U.S. Department of Health and Human Services can waive almost any Medicaid state plan requirement under Section 1902 of the Social Security Act. And so this is a type of Medicaid authority we're seeking. It allows states to really run their program in ways that are responsive to the unique needs in their states. And that's what we're looking to do here. All right, we wanted to share just a little bit before we get into it about CMS guidance and context. So we are seeking approval for several new and exciting benefits that address health-related social needs, including both nutrition and housing supports. CMS creates specific guardrails for states using the 1115 waiver for health-related social needs. And some of those, the key guidance includes that these services must be medically appropriate. So states establish the criteria of medically appropriate, and this definition can vary by state. And then expenditures on health-related social needs cannot be more than 3% of the state's total annual Medicaid spending. And the 1115 demonstration and health-related social needs activities come with a variety of reporting requirements. And then finally, before I turn it over, I do want to introduce this timeline. So everybody watching today will understand that there is still time for them to look over the material, think about it, and we really highly encourage folks to submit their comments to us. So this is the timeline that we've been working on. You can see that we got things kicked off on October 16th with the beginning of our public comment period. And we've had a couple of public hearings so far, one on October 18th, and then another one on October 24th. And again, we're very happy to be here today to share again. These public comments are due by November 16th, so that is coming up around the corner. So again, we do encourage people to look at the material and submit any comments they have. Then by February 1st, our Section 1115 demonstration application is due to CMS. So that's going to be February 1st of 2024. So between the time we get the public comments, we have some time to really react, review, and create what we intend to be a really robust and successful demonstration application. And then from February 1st through July 31st of 2024, CMS will conduct a federal comment period. They'll review the application and then have continued discussions with the state. And then in July, our current Section 1115 demonstration expires. So we will be poised and ready and hopeful that on August 1st, our newly approved Section 1115 demonstration will begin. And the implementation dates for new benefits and policies will vary. So not everything starts on day one of that new waiver period. But we do look forward to a successful approval, noting that CMS does have the ability to approve some of what we request, all of what we request, or none of what we request. And with that, I'm going to turn it over to Dr. Ranjani Starr, who's going to walk us through the current Section 1115 demonstration.
Thank you, Meredith. Okay, so before we launch into what we are going to be asking in our new upcoming renewal, we want to ground ourselves in what our current Section 1115 demonstration actually contains. Hawaii's Section 1115 demonstration, the current one, is grounded in the same HOPE project strategic roadmap that Meredith mentioned previously. And this is the roadmap that has driven the work that MedQuest has done since we released it in 2017. It grounds our current demonstration, and it will continue to ground our future renewal application. Based upon this HOPE vision and accomplishments, sort of the major overarching objectives of the current demonstration, which remain the objectives of the future demonstration, are to improve health outcomes for Medicaid-enrolled individuals covered under the Section 1115 demonstration, maintain a managed care delivery system that leads to more appropriate utilization of the healthcare system and a slower rate of expenditure growth, and address the health determinants to improve health outcomes and lower healthcare costs. So Hawaii has had a very long-standing 1115 demonstration, and while those terms are interesting and foreign to us, really this is our major vehicle for running our managed care program, the QUEST program. The first Section 1115 demonstration was implemented by Hawaii on August 1, 1994. It has been renewed 6 times since, continuously since then. And since it was first designed, it has continually been expanded to increase access to health care, control the rate of annual increases in expenditure, and serve as the mechanism for delivery of system innovation. So our current demonstration does that, and our future demonstration continues to build upon what we have already achieved so far. There are 4 major elements to our current Section 1115 demonstration. The first one, and kind of the most important driver of our entire Medicaid program, is our QUEST integration mandatory managed care, which essentially enrolls all of our Medicaid members, with very rare exceptions, into our mandatory managed care program. For those who are familiar with our Quest health plans. MedQuest contracts with 5 health plans in the community: Aloha Care, HMSA, United Healthcare, Ohana, and Kaiser. And these programs contract with MedQuest, and MedQuest makes capitated payments to these 5 plans to run the Medicaid program on our behalf through managed care. The second major element of our 1115 demonstration is behavioral health. Behavioral health is provided in 2 ways. So both through the Quest integration program, beneficiaries have access to standard behavioral health services. But for individuals with serious behavioral health illnesses whose needs exceed the capacity of most of our Quest integration programs, we do have a specialized behavioral health services program called Community Care Services provided by Ohana Healthcare Health Plan as well. The third key element of our current 1115 demonstration are home and community-based services. Home and community-based services are available to individuals who are disabled, who need additional supports and services to be able to reside either in a nursing facility or in the community. Home and community-based services are offered as an alternative to nursing facility care to eligible beneficiaries to allow them to live safely in the community in the least restrictive setting of their choice. The fourth and newest element of our 1115 demonstration is community integration services. This was an authority we were approved for in 2018, by which Hawaii provides eligible individuals with housing supports, including pre-tenancy supports, tenancy sustaining supports, and limited financial housing assistance, including security deposit and 1-month rent. In our renewal, we'll be asking to expand some of the community integration services authorities. So with that, I'm going to turn to a couple of slides that demonstrate what we have achieved during the current demonstration period before handing it off to our Medicaid director. I don't think it would be possible to talk about what our current demonstration, which began in 2019, has looked like without touching upon the fact that almost this entire demonstration has been colored by the COVID-19 pandemic and the resulting changes that have occurred. And one of the biggest sort of changes that our program has experienced during this period is the tremendous increase in enrollment beginning in March 2020 when the enrollment began. And over the course of this period, we have seen an essentially 43% increase in Medicaid enrollment, owing both to the fact that we stopped redetermining eligibility during this period, and also because there were job losses and other financial impacts that resulted in more people coming onto our program. We did begin and then paused eligibility renewals one more time of late, but we do anticipate that eligibility renewals will continue or will restart and continue over the next calendar year or so that by the time the new 1115 renewal begins in August 2024 or later, we expect the population to look quite a bit different than the population we currently have today. There is a long and very complicated demonstration evaluation that is present on our website along with the rest of the renewal application. The University of Hawaii led an external evaluation of our current demonstration. Here are some of the sort of key findings of that demonstration, but there's a lot more information available to you if you'd like to read through them. The major things that are important to note are that our evaluations show that 2 out of 3 Quest members are actually healthy with good health outcomes, and that despite the pandemic and despite all of the health-related impacts over the last 5 years, they remained healthy throughout the course of the 5-year demonstration that was recently evaluated. There were some transitions between groups, individuals in different health groups moving either from healthy to unhealthy groups or unhealthier to healthy groups. And we found that the group that showed the greatest transition was actually those with behavioral health needs, either psychiatric or substance use disorders, who actually showed the greatest transition to becoming healthy over the course of the demonstration period. In terms of healthcare spending grew in general over the course of the period, but grew at the highest rate for those in poor health compared to healthy individuals, further substantiating our efforts to try to support individuals who are in the high needs, high cost categories. In terms of total cost of care, the cost of care for those in poor health was more than 4 times higher than healthy individuals and more than 2 times higher than individuals with diabetes and cardiovascular diseases. Once again, pointing us to who we need to target more in terms of the efforts that we sort of focus on in our renewal. When you look at primary care spend, which is one of the key initiatives of the HOPE project and an intention for us to increase investment in primary care spend, we realized that during COVID-19, people were reluctant to go see their healthcare providers, staying out of the healthcare system. And so we noticed that primary care utilization dropped quite a bit. And since the end of the pandemic, we have seen an uptick in primary care utilization, but it has not gone back up to the levels that we saw prior to the pandemic. So we need continued effort to encourage people to receive primary care services so that we can continue to increase investment and in primary care as well as health promotion. In terms of home and community-based services, one of the authorities that Hawaii has that is unique to Hawaii is the provision of at-risk services. At-risk services are services that we provide in the home setting to individuals who are at risk for deteriorating to nursing facility level of care to try to prevent and mitigate that deterioration to the extent possible. We evaluated that program at length in this current demonstration period and found that the provision of at-risk services actually does successfully delay nursing home care, improves goal attainment, lowers the cost of care, and stabilizes costs for this population. So those are some very positive findings for the benefits of at-risk services for our populations. And you'll find that in our renewal, we are proposing to add more services to the at-risk population so we continue to stabilize their care in these home-based settings. Finally, in terms of our efforts to support homelessness, what we found is that there is a high correlation between those who were in poor health and those who are likely to be homeless. Obviously, the connection between homelessness and poor health is not new to us, but it was demonstrated through our data as well. We also found that those who were homeless or at risk of homelessness in our community integration services program had 4 times more emergency department visits and twice or more of the cost of care compared to those who were not in the CIS program, kind of demonstrating that our program is targeting the right individuals and starting to work toward improving the health outcomes of the right subpopulation that needs our help.
Dr. Ranjani, Dr. Starr, can I just interject?
Yes.
Really just quick question.
Yeah.
How many persons do we know are within the CIS program currently, if you have a sense?
So there's, when you say how many individuals, there's actually a few different numbers to be mindful of. I think there are about 13 to 1,500 individuals, I can look up the exact numbers for you, who have entered CIS in one way or another. However, there are capacity limitations from the provider perspective. There are also individuals who, who have sort of transitioned to different stages of the program at this point in time. So not all of them were stably housed. Not all of them have received pre-tenancy and tenancy supports. A lot of the last couple of years has focused on building up the infrastructure for this program. Working with the health and homelessness industry has been new for everybody, new for the housing service providers, new for us as well. And we have done a lot of rework to reboot the program and rethink how do we do the billing and claiming and things like that in a way that is supportive of them and helpful to us. So I would say that we probably have brought in a lot of people into the program. Not everybody has transitioned into receiving services. I think a subset of those, we may have seen about 300 to 400 who have actually started to receive services through the program. But I think we are really making a concerted effort to work very closely with the housing service providers to improve those, the prevalence of that.
And in fact, that's the whole point of the demonstration project, right? This was
Exactly.
started in 2018, so we're now evaluating it, and now we can improve it.
That's
and
right.
understand how to make it better.
Yeah, so this particular project has some extra evaluation resources dedicated to it through a process called rapid cycle evaluation. So we have a housing evaluator, an evaluator whose entire PhD and kind of their background was in working with the housing service providers, who closely supports them, continually does, every 3 months meets with all of the health plans, all of the providers, et cetera, to provide feedback and to kind of support the constant kind of rapid cycle assessment and program improvements for this particular program.
Thank you.
Thank you.
Question from our,
Follow-up, did you say 300 to 400
Somewhere in that range, yeah.
have been brought into the program?
Are receiving pre-tenancy or tenancy supports, yes.
And that's out of a population or potential population of how many?
Well, I believe that when we've looked at the number of homeless individuals in the Medicaid program, I think that exceeds 5,000. It could be even higher than those numbers. But
300 to 400
does not seem like a lot.
abysmally low.
Yeah, so the program implementation was, it took a while to get all of these pieces kind of implemented and running, and I think we are working toward improving those numbers, but a lot of it has been, I think some of the housing service providers haven't contracted with us yet. They had been sort of holding off and waiting till they were sure the program was working correctly. So I think we are working actively to improve that capacity. Would you like to add some more?
can I
Okay.
just clarify so the numbers, because I've heard different numbers. I heard 13 to 1,500 have entered into the CIS program.
Yeah, so he asked, how many homeless individuals do you know that you have in the Medicaid population?
Is
That's
5,000.
or more, yeah.
13 to 1,500 is in the
Have been
CIS.
somewhere in the program,
And then 300 to 500 are getting
services.
services. Okay?
Yeah.
Thank you.
Which is low, I think.
I agree. I think we're
Wow.
looking to continue to improve upon that. This is not, we sent out the implementation guidance and started working with the providers just in the last couple of years. It's been in the middle of the COVID-19 pandemic. There's been a lot of other things going on, but I think we are making good progress at this point.
I mean, if you just went to the homeless shelters, you could find a population at least equivalent to 300
No,
to 400.
I don't, apologies, respectfully. I actually think that we're, that the way that this process is working, some additional aspects around the community integration services is one, the services also cannot supplant other supportive, tenancy supportive services. So this is only one piece of providing services for the houseless population in our state. And so the homeless programs office, which I don't have the numbers for, they're very active and they're helping to provide services within the shelters, et cetera. So it's going to be a small subset to begin with, given our current waiver requirements that we would be working with. We did not start off from the day that we got the renewal. We didn't start off with, okay, day one, we're going to be able to implement the program. Part of the waiver and part of getting the permission to do this meant that we needed to build up the infrastructure, to build up the structures, to figure out how to build, to figure out how to do these things. And quite frankly, our first initiative for doing that was a few years ago, and then we started to use it out within the community, and we very quickly learned that it wasn't workable the way that we had set it up. So the team has been working very, very hard and very closely with them trying to do that reboot, that reset of the program. So to me, it's actually, I'm really, really happy that it's, that we're working with the 1,500, the 100 to 300,
300 to 500.
300 to 500 people, to me, is like it's indicative of a good start. That means that we're really starting to grow the program. So yes, we could have, learned more quickly. We could have done all of these things better. But to me, the fact that we are where we are right now, and that we've gone through this sort of learning process, means that we're well on our way and on track to be able to help support this program in really positive ways.
Dr. Peterson, I think and I apologize because I kind of took us down this rabbit hole, but let's continue with your presentation because I think some of these questions and concerns will be addressed further, and it really illustrates how this is a building process because there is what you folks can do as a Medicaid department, but the community also has to be ready. So in one of the responses I've heard that the service providers also need to be ready for Medicaid processes. And so let's go on and then we'll come back and circle back to these questions about CIS.
Okay, perfect, thank you. And so this is it. It's time
That
for
was
me
it.
to hand it over to
There we go. What a nice
our
bit of
Medicaid.
segue here. Okay. So before I get started these are some of our new initiatives that are going to review, like what are we going to continue, what are we going to adjust, and then what are we going to do newly. So I wanted to note that each of these things ties back to our mission, vision, our goals, ties back to our hope vision. So you'll see investments in primary care, which are really the long-term investments within the community well-being and whole person, whole family, and whole community health. If you don't have that long-term investment, then and that focus on primary care, then you're never going to sort of create your overall well-being. At the same time, you'll also see the investments in individuals with more complex needs and high-cost needs. We do have some efforts. Currently, we don't need a lot of waiver for doing the financial alignment, although that might change depending on what direction we go and depending on what CMS does when it comes to their overarching rules. But each of these things, and quite a few of these things, also depend on working with our community and our community initiatives. And in some ways, the CIS project is actually a perfect example of that. Because within each community, they have different processes and workflows, et cetera, that they're doing. So that makes so that's how our overarching waiver and demonstration waiver actually helps support and is part and integral to our mission vision and our hope vision. All right, so currently, as Dr. Starr noted, our Quest integration, mandatory managed care, and our behavioral health are in our current authority, and we foresee very few changes. There'll be some technical updates to them, but no major changes. So currently, most beneficiaries will continue to be mandatorily enrolled in managed care plans. So 99% of our population, actually more than 99% of our population, is in managed care. We only have a very small population that's not in managed care, and those individuals are need transplant services, which they're not able to get those transplant services here in the islands, and they have to travel to the mainland to get those services. So, and we intend on continuing with the 5 managed care plans to provide most of the services and benefits. The only benefit that's not within managed care currently, or the major benefit that's not in managed care is actually our dental benefit, which is done by a third-party administrator. Within our behavioral health program, we do continue to provide the services in a similar way. However, we're always looking for ways to improve the continuity of services and improve how those are provided. I will note that a lot of times when we're thinking about and focusing on behavioral health in particular, we're talking about very disparate systems. And the key is that no matter how you are organized, you have to pay attention to how those services are integrated. You have to look at not the nodes of the services, the blocks, or as one of my colleagues used to call them, the cylinders of excellence, not those areas, but you have to pay attention to those connecting points, those synapses and how they work. So I think we're actively engaged in trying to figure out different ways and better ways that we can provide the full range of behavioral health services, with Medicaid just being one part of it. So within the home and community-based services area, we have currently 17 services or waivers that are provided. Sometimes, and this is, I'm not trying to get down into the numbers, but sometimes people, they refer to these home and community-based services, and they ask us, why don't you have any 1915C services? And what I will note is that there's only 1915C is another type of waiver that you can use to provide home and community-based services. In our state, we have currently only one active 1915C waiver, and that's through the intellectual and developmental disabilities home and community-based services. That program is operated through the Developmental Disabilities Division within the Department of Health. We consolidated the number of the other 1915C waivers, I think way back in 2009, could have been before then, but for sure in 2009 within the Quest program. So you will find all of our, what you'll find in other states, you'll find all of our 1915C, so-called 1915C, home and community-based services in our 1115. So, and those services, they range from adult daycare or adult day programs, assisted living facilities, community care, foster family homes, counseling, training, environmental accessibility adaptations, personal assistance, personal care, home delivered meals. So there's a full range of those services. A subset of those services are available for the assisted living benefit, and I'll talk a little bit more about that in just a moment. But assisted living services can help avoid or delay nursing facility placements, access to personal care, supportive services, and then we also have some public health emergency flexibilities that are currently exist. So those are what we're going to be continuing, and then what we're going to be focused on improving. So again, current home and community-based benefits, individuals, one of the things that one needs to know is that we have two different types. The majority are in the institutional level of care. That means that you have to do an assessment. And so it's not just that they have a disability, but they actually have to meet a certain level of need in order to stay at home or in a home-like setting. And so those individuals are eligible for many home and community-based services, from home modifications, assisted living, alternative residential settings. Individuals who are at risk means that they haven't met yet that threshold or that level of needing the institutional level of care. And that particular group is eligible for a limited subset of services. For example, the private duty nursing, adult day health, those kinds of sets of services. So again, they don't meet the institutional level of care, but they do get some care within their home that will allow them to stay at home. So one of the two things that we're working on updating and changing, two proposed changes. One of them is to add an additional service for those who are at risk, so they don't meet the institutional level of care, they don't meet the nursing facility level of care. And what we're looking at is adding the assisted living facility services for the at-risk population. So currently, assisted living facility services are only available for those individuals who do meet institutional level of care. And assisted living facilities are unique in that sort of alternative residential settings, in the sense that their model of care is to allow people to come and live in those, within the assisted living facility before they have severe needs that would have them meet the nursing facility level of care. And then they can, as they have more needs, then they can sort of progress into different parts of the assisted living facility. And so this model would allow individuals who are at risk to be able to go into the assisted living facility before they would meet that nursing facility level of care.
Can I just pause here, because I think this is really important to understand. Does this new change then shore up kind of the flow of people from home to institution? Does it include assisting living facility services that may not be 24/7, but it might be just initially daycare?
Correct.
Or in-home care,
Mhm.
and then moving all the way towards potentially having to actually be in a facility?
That's correct.
Okay, so
Yeah.
really important because that's a big gap now. Correct.
It is currently. Well, I mean, that people can get care at home, and most people, they want to stay in their own home, but that's not going to be the possibility for everyone.
Okay. And again, this is going to be something that's going to be for a Medicaid eligible population, but again, shoring up kind of those abilities to somewhat age in place, but as you need to move also to get services where needed.
Correct,
Okay.
correct. It is a gap area, and we are hopeful that this will help add one more tool, sort of in the toolbox to help that gap area.
And would this also help that kind of range, help to develop that range of, and I always get so confused because there's so many home health facilities, arches, e-arches, all that. Will it help to shore that part of our ecosystem up?
It is one of those. It is one of those areas. So there's within the Medicaid area, we have people who were paying for services within community care, foster family homes, and within expanded adult residential care homes. While we do have people who are living in adult residential care homes, they are not receiving home and community-based services because those arches, they don't meet the nursing facility level of care because they don't have nursing as part of their service array.
Thank you.
Mm-hmm. Okay, so the other thing that we're also including in this waiver is to be able to continue some of the flexibilities that we obtained during the public health emergency for the COVID-19 public health emergency. And those include a range of services such as being able to provide some assessments, et cetera, using telehealth, using electronic service delivery for some of those services, to get signatures instead of a wet signature, that you can actually get it electronically. Some additional for case management. We're actually also looking at continuing and expanding, being able to pay relatives to be able to help care for their individuals, which is actually another big flexibility that actually has been very helpful for the workforce in general and for families in general during the pandemic that we're looking to continue. Okay, so now we're going to move along to, we've already begun quite a bit on the community integration services. And so here's a little bit of the context, which we've already spoken about, but which I think everybody here knows, but homelessness and houselessness for Hawaii has been a huge challenge for many, many years. And then, so we have really some of the highest rates of homelessness in the nation. And we also know that addressing homelessness, as this committee knows, and as this administration, Governor Green, and our agency, et cetera, addressing homelessness is a huge priority. We really want to look at various different strategies and tactics that we can use in order to be able to address homelessness. And including if there's additional ways that we, as the Medicaid program, can help support it through the Section 1115 demonstration. We're also looking at, we also recognize and we know that if you are able to address homelessness, that there's a hand-in-glove relationship between individuals' ability to address their health needs and whether they have safe and stable housing, and quite the reverse as well. If they have access to health care and they're able to keep it, then they're more likely to be able to sustain and keep their housing. So those things, two things, actually go hand in hand. We also know that CMS has approved, and they've approved our current level of community integration services, and the ways in which we're looking to expand. CMS has very recently approved similar housing services in other states, including Oregon, Massachusetts, and I think also California. So our current community integration services benefits include outreach, pre-tenancy supports. Those are examples of where you're getting someone ready for their housing. So you might be able to go out and take a look at properties. You can help them fill in the rental agreement. You can explain what it means. It also includes tenancy support services, so helping people understand and work with them on getting the things that they need for their housing, understanding what being a good neighbor means and what some of the restrictions and positive things that they can do. It provides very limited rental assistance currently, one-time security deposit, and just first month's rent, which you would need sometimes just to even get into that place. And it does also includes utility setup and one-time utility payments. So we're looking at expanding this quite considerably. And I will note that up to this point, until like November, December of last year, CMS had never approved this expansion before. So this is the first time, and we are going to be going into that line, and if they're going to approve these things in other states, we're hopeful that they'll look at ours also favorably. And we wanted to be as expansive as we could be, given this opportunity, which we don't know how long it's going to last. So we're just going to go for it here and put this in. So one of the things that we're going to be doing is expanding the scope and the duration of the rental assistance to newly include the housing application costs. A lot of times you have to include that, including document recovery, and sometimes you have to turn in an application fee itself. We're also going to be including a request for utility setup and up to 6 months of utility payments to help sustain those individuals within that home, and include past due utility payments. So the current CIS program is for those individuals who are either houseless or at risk of being houseless, and that could include, and it has to be medically necessary, of course. It has to include, so that's why we can also include the past due utility payments as well. And sometimes that's actually a barrier to getting into a home, is if you have past due utility payments. We'll also include, and this is brand new, CMS has not done this before, up to 6 months of rent. So these expanded benefits are in addition to our current existing rental supports. Like we also include some things like moving costs. So I want to note that here also that currently, because it came up earlier, that currently CMS has a requirement that these services cannot supplant. In other words, if another program, federally or state or even county, is paying for these services, then Medicaid could not pay for it, which what ends up being a barrier. Just the way that the homeless programs office works and the city and county work, et cetera, it's actually very difficult to sort those things through. And with these more current approvals, CMS has changed those terms in these other states, and we would be hopeful to change it ourselves as well, to being more like a maintenance of effort. In other words, the state, county should commit to spending or continuing the same efforts so that Medicaid isn't replacing, but is rather adding to the ability for the state to be able to address this issue, which is significantly different than not being able to supplant. In other words, if it works out that Medicaid is the first payer for the 6 months of rent while an individual is waiting for, I don't know, their Section 8 housing or something like that, their application, they know it's coming but it hasn't gotten there yet. So then that, it could be used first, as opposed to if that's being paid for using this other mechanism, then Medicaid could not pay at all. So this is it is a significant change within the financing part of it and those terms and conditions. Then it will be something that we'll be seeking to change in our current waiver application.
Okay, because this is so critical, I'm gonna ask some questions now, and especially because it's so critical to our committee as the Committee on Health and Homelessness.
Mm-hmm.
This conversation about not supplanting.
Mm-hmm.
So, let me back up. When you say that other states have received this waiver, so Oregon, Massachusetts, and California have some versions of adding these additional services for more tenancy supports. Is that correct? But our application now is going to be pushing it a little bit further for a longer duration of 6 months. Is that correct, to what I've heard?
Actually, no. These other states got the 6 months.
Okay.
And so we're modeling what those other states did, because I don't know that we're pushing the boundary on this particular topic. CMS has been pretty, we'll approve this.
Okay.
From their perspective. That being said, if you all had ideas and you said, we really think you should go beyond that, you should expand or you should consider that, then those are the kinds of public comments that we would appreciate hearing back from. We'll include it. We would, evaluate, do we think this makes sense, et cetera, and then.
Well, I actually like the approach that it's actually in alignment with other states that have already received the approval, because then this means more likely that we can. Then the second follow-up question is, because this has to be kind of coordinated so that we don't supplant already existing funding, what are the kinds of conversations you've had to kind of design this new benefit? What kind of conversations have you had with your other sister state agencies, as well as county agencies, in preparation for perhaps, this is ground changing.
Mm-hmm.
This is changing the dynamic. And what I'll share with you, I was at a conference on Friday where there were over 500 service providers. When this slide came up by your staff member, Mr. John Fujii, cameras came up from all of the service providers, and you could just see and hear the oh my goodness, everyone stood up a little straighter. This is going to make a difference. So my concern is that this is only going to make a difference if all of our agencies are in collaborations. Have you started to take those steps to educate the rest of the ecosystem to get ready for this?
We have begun those conversations, and it is a matter of us working together to design a system together. So it's not a matter that Medicaid we're not supplanting anything, but how can we be part of strengthening and building this particular program. So we've had some beginning conversations with the Homeless Programs Office, of course, which is also housed within the Department of Human Services. We've had many conversations, well, many. We've had conversations also with the governor's coordinator on homelessness, Mr. Koshiba. And so we've also been having conversations with the providers that we're working with now, on our current community integration services, and who have also been advising us on, hey, how you're doing this doesn't work. They're part of that reset, right? And so they've also been very active with us in having these conversations. That being said, because this is such a major change, that in trying to think through this, et cetera, there's some parts of this where we know that much more in-depth conversations need to happen for the implementation part of this. Part of what we're intending on doing and how we've been investing in our own energy and resources, et cetera, is it's taken us a lot of work to even get this, our waiver proposal together on what we're doing. And so we've intentionally left the nitty-gritty details of the implementation side of it. It's not that we've ignored it entirely, but we're just putting those conversations to the side for right now. And then once we submit, and then we're going through the negotiations with CMS, we intend on investing those same kind of resources then on the implementation side. So that's when those active conversations on, okay, what exactly does this look like? How would you want to put this in place? So the states that have the 6 months of rent, et cetera, we've also emailed them and said, hey, we'd be really happy to see your operational protocol, because CMS actually has to approve. It's like, well, how are you going to do this? How are you going to implement it? They actually have to approve that. And those states are still working on them. This is so new that those states are still working on their own operational protocols. So we understand this is going to take it's just going to take some time in order to get this up and going.
Okay, and a follow-up. So another reason, and I think this is really important, because this is not a lengthy process, but it takes time. We've been talking about so many of these things in our committee for 5 years, and now we're seeing it on paper. For the public to understand, the reason why the federal government is so involved is because we, in fact, will get a match for these services. So can you explain that a little bit? And so that when we're putting up, say, 50% of the 6 months rent for X amount of people, the federal government is also putting up money. Can you explain that to the committee?
Yeah,
and to the
happy
public?
to. So the Medicaid program is a federal-state partnership when it comes to the financing side of it. It's actually also, it's a non-discretionary program. So it means that if you have an expenditure within the Medicaid program, if there is a medical need, then you will pay for it. And so if someone is eligible, you will cover those individuals in the Medicaid program. And by that, what that means is that for every dollar that's spent, currently, for these kinds of programs, it's about 45 cents is the state portion of it, and then the 55 is the federal portion of it. So it's more than half. They're paying more than half, and so and for some of the populations, it's actually the federal government is paying 90%. So that would be individuals who are what we call the low-income adults. So they're not in families. They're low-income adults up to 133% of the federal poverty level, and that's the criteria. And the federal government pays 90%. Many individuals who are houseless actually are in the low-income adult population, so CMS cares very deeply about, and they have a lot to say then about how it is that we operate our program. And we talk about it as a federal-state partnership, but there's, they're the oversight body, of course, but they they do work with us then in putting together the operational protocols, in negotiating the waiver terms, et cetera.
Again, I think, and it's really important because we get that it's a federal-state partnership and it's federal resources. It's
That's
us
correct. It's
maximizing
federal resources, yeah.
And then one last question on this. For this new CIS Plus benefit, are there also conversations with insurance managed care plans? Do they play a role in making sure that these benefits get administered to the appropriate people within Medicaid?
Yes, actually, as I was noting earlier, this particular program is our particular program is 100% managed care, and so they are the ones who are getting the contracts with the community-based organizations, et cetera. So when we've been talking about doing the reset, it's not. I mean, we're there at the table having these conversations as well, but it's actually also with the managed care plans. It is there. They have housing coordinators themselves, and they're the ones who are working with individuals. They'll work with case management agencies. Some of them have their own case managers, et cetera, housing coordinators who go out and meet with people and help them.
And I would note that for managed care plans, typically, housing is not within their wheelhouse. So
This
that's
is
why
not in
that's
their
why this is
wheelhouse.
another kind of
Yeah.
innovative experiment that we are doing as one of the healthiest states in the nation, frankly.
Yeah. I mean, we're one of the healthiest states, but we also recognize that we have huge disparities among certain populations. Individuals are houseless, or obviously they have very severe and serious health issues. They have some of the poorest health outcomes in our state. Many individuals, there is that cross section. It's by no means the majority, but many individuals who suffer from mental illness or substance use disorders, or the combination thereof, they're particularly challenged by having in getting housing and keeping housing, et cetera. So we know that we have a lot of disparities, health disparities, and having these kind of programs help us address that.
So I don't want to, I focus so much on the left side of the proposed changes. I don't want you to forget the right side, because actually
Right.
that is right in our front door,
That is right in our front door.
at the governor's feet as well.
That's
So
correct.
can you speak a little bit about the medical respite?
Yes, and this is one of those ones where we actually had requested medical respite in our last waiver application, and we were turned down. No, they did not tell us no. They told us not yet. We're not
Okay.
going to approve it yet. And so in the intervening years, again, this is another one of those areas that they have only recently approved. They've approved it. California has a version of this, Oregon, and I think Washington now as well. So recuperative care and short-term post-hospitalization housing. When we did it, we only called it medical respite, so that's why we just have the title here. And so it's for individuals who maybe they're coming out of the hospital, they don't need to stay in the hospital. They're ready to be discharged, but they do have continued health needs, and they don't have access to stable, safe housing. And so we're able to provide 90 days of short-term residential care that provides for ongoing medical and psychiatric needs. And then also the short-term post-hospitalization housing up to 6 months for who don't have a residence to continue recovery for physical or behavioral health conditions following an exit from an institution. So institution would be like a nursing facility, hospital. We'll see how far we can push these as well. But in the intervening years, there's actually been a growth in our own state from when we first asked for this and then did not get it at the time. There's been a lot of growth in our state in the investment in medical respite. So we're very excited about this. So today, we would be able to pay for the wraparound services, but not the actual housing itself. And this helps us to provide for that actual housing.
Question, Representative Kobayashi?
So, right out here, a couple hundred yards from us,
Mm-hmm.
we have those little,
Kauhale.
Kahole. Mm-hmm.
Would those people be covered by this,
Yes.
right-hand portion?
Yes.
And would those people?
Well,
of
presume if they're Medicaid eligible. So,
I would
yeah.
assume most.
I think most are. It may not be all, but most are.
And would that also cover neighbor island people in
Yes.
similar circumstances?
Yes. And that's actually, I believe, there's a medical respite opening, maybe in Hilo, with Hope Services, I believe.
Okay. We just heard that Kauai could use some,
I'm sorry. Where?
the island
Oh, yeah.
of Kauai has some people that could use the services similar to what we have out here.
Yeah.
Okay, thank you.
So just to build up on that and just to really make it a point then, so currently Kauhale are being stood up with state general fund resources, mostly,
Right.
to
And-
your understanding.
And some donations, et cetera.
Right?
Mhm.
So this benefit is actually going to systematize it and put it into a more sustainable framework so that we can support this going forward
It is.
with the help of federal funds.
Correct. It's an additional resource. We can't pay for the actual building. You know, Medicaid doesn't pay for capital investment. It's not that portion of it. But for the services, for the, what one might consider the room and board, we would be able to provide that.
Okay.
A concern that has been happening for years is that sometimes people get rent benefits or housing benefits, but are unable to use them for a variety of reasons, including the fact that the benefits are not high enough to go out to the market and secure available housing. Is there a limit to how much rent can be paid per month?
There's no dollar limit, but you also have to take into consideration that this is very short term. So if you were housing somebody in a location and you were not able to sustain that individual over the long term because they didn't have that subsidy or they didn't have a way to sustain that rent, then I think one of the things that we would not want to do is set up a situation in which those individuals would only have 6 months of housing. And I think that speaks to the larger issue within our state of the affordability of housing, the access to that housing, and how it is that we're able to do that. And that is not something that the Medicaid program does and works on, although we have a lot of concerns about it and are happy to participate in those conversations if there is a role that we can play. But I believe that is something that your committee and other committees that are looking at housing and homelessness, et cetera, are well aware of, and looking at other kind of ways to help solutions, community solutions in that particular area.
So let me get that.
Mhm.
There is no rental payment cap,
From the Medicaid side,
right?
that is correct.
Okay.
I think that in thinking about what's best for the overall well-being for that individual, we would be wanting to look for, even without a cap, and so there'd be no cap, but looking for how is this sustainable for that individual over the long run as part of their overarching plan.
So if I can interrupt, let me try to clarify this question. So in other committees, we're having conversations about the need to build and finance supportive housing, permanent supportive housing, that might be targeting a certain low AMI. It's in that space where we might be talking with the housing committee to finance those projects, where then you could step in with a developer to talk about potential supportive housing wraparound services if the Medicaid eligible community is living in that supportive housing context.
That is correct.
Okay, so what we're really talking about then is that homelessness committee has to shore up the infrastructure to make sure the services can be provided. And the housing side representative has to really focus on, and this is what the governor's team is doing, on building quickly more affordable housing units that are throughout the continuum of price range, so that we can make sure that there's all these types of potential places, so that people can actually graduate, right?
Yeah.
From transitional housing, well, let's go back. From
Emergency housing.
from emergency housing, recuperative housing, medical respite,
Transitional.
homes,
To
Section 8
permanent.
housing, and what the ultimate solution is, permanent, affordable housing. Like,
That's
that
correct.
is the entire range of things that we're working on.
That's correct. And then we're part of that. We're part of one piece of that puzzle.
Okay, I think we're good on this piece,
Okay.
and there might be more questions, so let's move on.
Okay.
Might take
We-
all day.
Yeah, we have very many exciting things that we're thinking about doing and focusing on. So another thing that we're including in this conversation with CMS in our waiver that is actually also new is focusing on continuous coverage, continuous eligibility. So for kids. So we know that consistent coverage is very important for overarching children's health outcomes, especially in the early years. So if there is constant disenrollment and re-enrollment, sometimes called churn, it results in periods of uninsurance, kids not getting the developmental screenings that they need, delaying care. And this is particularly problematic for young children during their most vulnerable times, the most amount of development that they're going through, the most number of wellness visits that are required and projected. And so having kids having access to ongoing coverage and that continuity of coverage can be very, very helpful. As the other context for this, currently we cover about half the state's children today. And so, and part of the reason that we're also taking a look at this is we're coming out of a time period in which we just had continuous coverage for 3 years. For if a child came in March of 2020, they had continuous coverage during that entire time period. And then CMS has just changed the rules so that they're now continuous coverage eligibility is a requirement for at least 1 year. And so Oregon and Washington have actually also just approved consistent coverage or continuous eligibility coverage provisions in their states. When we were taking a look at this, we looked at the more expansive of the two, which is Oregon, and are modeling our request on theirs. And so what we will be proposing is continuous eligibility for children 0 to 6. And so they would have continuous Medicaid coverage for that entire time period. So what that means is that if they had any kind of change in circumstance that would cause a loss of eligibility over income, et cetera, they would continue to retain their eligibility, their Medicaid eligibility until until they reached 6. Of course, that does if they requested to have their eligibility stopped, if they passed away, or they were no longer a resident of Hawaii, then that would end. We think that's a real positive, especially for that particular age group. And then the 2-year continuous eligibility for 6 to 19, that would add 1 more year of eligibility as to above what is currently required. And again, it's just another way to help focus on our keiki, et cetera. We've done a bit of the analysis of, well, how many more people, and by the time you take into consideration the churn that would not be the churn, and then coming out of the past few years, this actually would not add any significant budget. So it's another reason that we feel taking advantage of this moment in time in which we are experiencing continuous coverage for kids is a real positive.
I don't want to spend too much time on this area, but I want to ask the question, does this kind of continuous eligibility over a longer period of time assist with kind of services that our children who are in the public school system might receive, both through school-based services as well as what they receive in the community through Medicaid?
Well, clearly through all children, whether they're in school or not, or not in school, if they're Medicaid eligible, they would have full access to all the services that they would normally be, that they would have access to. When it comes to working with the schools, with the agreement that we have with the schools where they're able to provide some services directly and then bill us directly for those services, then there would be more kids covered, or potentially more kids. We feel like we're kind of at the cap right now. We haven't had a lot of increase in the number of kids recently, probably because we are covering so many today. So it's probably not going to go up a lot more than what it is at currently. It might go up a little bit.
Okay. All right, thank you.
You said probably not going up much, but you're already covering about half of the children.
That's correct. So as you have new kids being born, as you have kids aging out, there might be some fluctuations up or down. And then sometimes there's a very small percentage of kids in our state, I think it's like 2% right now, who are uninsured, where there's potentially, for whatever reason, they haven't known that they could be insured, and so they could apply.
While the number of children being served might not go up very much, it probably won't go down very much.
That's correct.
Because Jack Lewin 1,000 years ago was talking about universal health care coverage for children.
Yes, actually, he's the one who in working with Governor Green, asked us to consider this, and so that's one of the reasons that we're moving forward.
Oh,
I know.
All right,
Okay.
I think we're good. I think if you have any more questions, I'm sure we'll follow up with this area.
Okay. Okay. We barely touched what we're doing here, so move it along. Okay. So I'm probably not going to spend a lot of time on this, but I will note that Hawaii, we do have a relatively high substance use disorder rates. We have overdose deaths, outpacing auto accident fatalities, and in particular, our rates of methamphetamine use, I'm going to just say for meth from now on, use disorders are quite high. It's one of the highest, if you're looking at all the, especially illegal substances, alcohol outpaces meth, but for the illegal substances, meth is the top. It's while opioid use is definitely growing, and of course fentanyl is a concern. It continues to be meth, and then of course alcohol. So contingency management is a way of offering motivational incentives to advance substance use disorder goals, and including cash equivalents for negative drug tests as an example. We also know that contingency management is one of the most effective behavioral interventions for treatment of substance use disorders, in particular for meth use. And it's actually one of the only ones, evidence-effective behavioral intervention for meth use. And CMS has approved contingency management in a couple of other states. And so we have been looking at those other states. So we are going to be proposing this in a pilot to start this off and see how it works, and then look to expand. And I should have said this at the very, very beginning, in that waivers are, these kind of demonstration waivers, they're aspirational in the sense that you can ask for the flexibility, and then you don't have to implement it. Of course, we want to implement everything that's here, but sometimes things don't work out, or you don't have the resources to start off, et cetera, and so you don't implement it right away. So we don't believe that all of these initiatives will be August 1, up and going. You know, that is far from what will be. From August 1 is when some of them will continue, some of them will be able to hit the ground running. Some of them, they're gonna take years, possibly even the entire 5 years, in order to get them up and going.
I want to pause here, Dr. Peterson. I think that this is a very important part of your waiver, and as a preview, this committee is going to be looking at the Department of Health's initiatives around opioid settlement funds. And so that is going to be, we're working on an informational briefing that's going to focus in on what's happening in that arena. We know that you folks can't do everything, even though we know that you guys are doing a great job with this waiver. There are actually other parts of state government that have to work on the content, the delivery of services. And so we are going to also be looking into this, and I think that this request of the federal government will actually set us up nicely for the next 18 years of how are we dealing with addressing substance use orders. We should have been probably doing some of these things earlier, but we don't have the tools in our toolkit yet. And so I really appreciate that you folks are working on this, and I know you're also working along with community partners to make sure that this request goes into the federal government. Did you want to respond to anything that I just said?
The only thing I would want to add is that actually contingency management, Department of Health, Alcohol and Drug Abuse Division, they can already provide this, and they did provide us some input into this, and we will be working very closely with them on the implementation. And you're correct. We also have spoken with several organizations, community-based organizations, providers who'd be able to help us pilot this.
All right, thank you. I think the next one is probably, yes, this one. Let's talk about this one.
Is this an exciting one for you?
All
Yes.
exciting.
They're all exciting, yes. I can tell that you all are very enthusiastic about it, and that's, to us, this is very heartwarming. We're very glad that we're moving in a direction which has a lot of support from you and from the community in general, and obviously from the governor. So this is another one in which CMS, again, had never approved before. I think January or this spring is the first time that CMS had approved it, and they approved it in California, and now they've approved it in Washington. We only have 2, and then CMS actually put out a guide that said, guidelines for this particular one, in which they sort of said, again, we will approve this. And so we have hewed to those guidelines very closely because we really want this to go through. And so, and then there were some differences between what California had and what Washington had. Washington had a couple, and I won't be able to remember what they were, but had a couple of things that were a bit more expansive than what California had. And in deciding where to go and how to consider it, we chose the broader. That was our choice, to always go with a broader if we could support it. And so just as a little context, the justice of individuals who are in jails or prisons are not, they cannot have, they're prohibited from having today, from having active Medicaid enrollment. So if there is any inreach into the jails or prisons done by healthcare providers or by the health plans, et cetera, it is not paid for by Medicaid because those individuals are prohibited from being covered by Medicaid. And so, but we also know that a large proportion of the justice-involved individuals have, and they re-enter the community without the necessary medications, without the transition, et cetera, despite the efforts that we may have currently in trying to help that. It still is very difficult to make that happen. And so there's oftentimes gaps in coverage. Again, we have an outreach team who tries really hard to get people on from day one, but it's very, very challenging. And so we also know that the justice-involved individuals usually have, or oftentimes have significant health needs, mental health, substance use, chronic disease, and have higher rates of many, many different diseases. So again, as I was noting, CMS has shared guidance on the provision of these services. And so we are following that guidance. And so for up to a 90-day period prior to release from state prison, local jail, and or a youth correctional facility, we will work to get individuals enrolled in Medicaid, and then they can receive case management and care coordination. They can receive clinical consultation for both physical and behavioral health, lab radiology services, any durable medical equipment we can get arranged to have, and then a 30-day supply of medications, including medication-assisted treatment. That's actually one of the required things for use of post-release. So a couple of notable things here is that there's some things that we are allowed to provide beyond that minimum benefit package. And the minimum benefit package includes the case management, medication-assisted treatment, and the 30-day support of clinically appropriate prescriptions. That all those things are still not intended to shift current costs that are being borne by the prison system to Medicaid. So Medicaid is CMS, which is our regulatory body, is pretty clear about that. And so it actually does not absolve them from providing those services. And then we should, once people are in the community, all other services that Medicaid provides, including some of the other waiver services that we're already talking about, like the community integration services, they can be provided. A particular area, that's United Healthcare. And then we have a few healthcare providers who, they're Medicaid providers, but they voluntarily are going into the prisons, et cetera, in order to help do some of this work, and they're super excited. And I would say of all of these benefits that we've put together, that we've put out there, I have never received as many requests and forwards of anything that CMS has done when it comes to waiver than this one. I think I got it from 15 separate people, community-based organizations, et cetera. So we know there's a lot of support out there. We're already in conversations with the Department of Public Safety, who I can't remember their new name. And so we've already been talking with them and with many community-based organizations on this particular measure. But
I'd like to ask a few questions here, because I completely agree, and I have to, you answered one of my questions already, is whether you've been in conversations with formerly PSD. So Director Johnson is on board.
Yes.
And I also understand is the governor's office helping and assisting with policy.
that is also correct.
And that would be Dr. Michael Champion?
That's correct.
Okay, so there is a whole government approach to implementation of this benefit if we're granted it from CMS, is what I'm hearing. And then I want to actually publicly apologize to you, Dr. Peterson, because probably on your first day, one of the first things I asked you to do was, why aren't we doing this? Probably 5 years ago, not understanding that in fact we have to do this through the process of this federal Medicaid waiver. And so I appreciate that you've been listening to me for the last 5 years as I've said, why aren't we doing this? And I've been pressing people to get into the prisons to do this, because I think we could have done it, without necessarily Medicaid being there. But Medicaid being there as a partner actually helps us, and helps us do the work better and in a more sustainable way. So I really would like to echo that this is a very important piece of this process that we're going through right now. And this is something that I think lawmakers on this side of the table are very interested in.
Agreed.
I got agreement from here.
Yeah.
Any other questions on this?
Okay. All right. Okay. Hopefully we'll make it through here. So, all right. So this is an area where we actually are very, very excited about this area as well. These are nutrition supports. For the context, we know that in Hawaii, that many populations, but particularly those of Native Hawaiian, Pacific Islander, and just people who are low income in general, they experience food insecurity at more than double the rate of others within our population. We had a pilot here that was sponsored by the Centers for Medicare and Medicaid Innovation, which is a part of Health and Human Services, and they noted that in that pilot, which was here on Oahu, the number one health-related social need was food insecurity by a lot. And so, and then the pandemic really highlighted this for our communities. We also know that nutrition supports make a huge difference to individuals, families, pregnant women, keiki, people with disabilities, our kupuna. It makes a huge difference in their overall health and well-being. It's associated with reduced need for costly medical interventions, hospitalizations, and ultimately lowering healthcare expenditures. And CMS, again, they have approved nutrition supports in other states. So CMS has categorized these supports into 5 different categories, ranging from nutrition education to medically tailored meals and groceries. They also include fruit and vegetable prescription or protein boxes, meals, and pantry restocking. So each one of these they need to be, again, like all the health-related social needs, these nutrition supports, they need to be medically necessary. They have to have some kind of a medical need and medically appropriate for individuals. So what we're looking at is for individuals who either medically appropriate and also or are experiencing a major life transition. So we're looking at nutrition education. I'm not going to read each of these because that would take quite a bit of time, but it's being able to one-time provision of cooking supplies, gardening supplies, which goes a bit beyond what the traditional nutritional education is. Nutritional counseling itself, it's like, here's what you need to do to maintain your health, is already included as a benefit within our state plan, so we don't need a waiver for that. So this is whatever kind of nutrition education goes beyond that, goes above and beyond that nutritional counseling. The boxes, the fruit and vegetable prescription boxes, that we're including also. This applies to grow fruits and vegetables. We feel like that's a real support of within our state with a lot of the move towards self-sufficiency within food and food supports, especially access to healthy foods. That's another way in which it could be part of that. It could also be vouchers, cashback rebates, direct provision. Again, this is not to provide this fruit and vegetable prescription boxes. It's not for all food, right? It's not for covering all meals. And it's actually also, these also cannot supplant if they have SNAP or SNAP benefits, or if they have WIC, et cetera. So it's to go to individuals who don't have those things, or to wrap around those things. So there's actually meals and pantry restocking. This is an example of also how children can qualify for WIC, or pregnant women can qualify for WIC. And this meals and pantry stocking is for pregnant women or for kids. And again, this is an example where it would not be replacing if they had WIC, et cetera, or SNAP. And then medically tailored meals, it's either pre-made meals or the provision of groceries and then cooking supplies to help a beneficiary in adhering to a meal plan. So a lot of that, kind of goes hand in glove. If you can imagine someone with diabetes, they're going to need, if they change how it is that they're eating, et cetera, in order to manage their diabetes. This is an example of some things that we'd be able to do. Oops. Any questions on this?
I do have one question, because I know that I have colleagues who will be interested in this. Will this area be an opportunity for us to connect with local farmers to help promote kind of this healthy eating, sustainable growing, local, supporting local agriculture?
That is our hope.
Okay, thank you. So we will also send this out to our allies in the food insecurity community who are discussing these issues, to see if they would like to comment on this also exciting benefit.
Yeah.
Thank you.
Yeah. Thank you. And I will say that not everything that we've outlined here has been approved in other states, but we're gonna include it and then see what happens. I think we know that we think that we have a really good case for it, and then but we'll see how that goes. Okay, so this is a new area, and one of the things we've been talking a lot about addressing health disparities and creating some health equity, and we have great examples in our state of this kind of healing practices, which take a holistic approach to one's health and to the family and to the community, all wrapped up into one. And we have examples of it being promoted. So within our state, evaluated, studied, et cetera. And one of the biggest areas of resilience, both, is within the Native Hawaiian community. So we're actually seeking authority for traditional healing services, but specifically Native Hawaiian traditional healing services. As I already noted, there's disproportionately health disparities, but we also know that Hawaiian health is good for humanity health. And so if we're able to combine these things, we believe that we can really, truly help address health disparities and really have a different approach to overall health and well-being within our state. So to date, although many states, no, I shouldn't say many, there are many states that have applied for indigenous healing practices, but they've been largely focused on Native American traditional healing practices. We would be the only ones looking at Native Hawaiian traditional healing practices. So we do not have examples of, we don't have any examples of approved Native Hawaiian healing practices or any indigenous healing practices. What we do know is that, well, I'm just going to move along here. So one of the things that we do know is that when CMS is looking at any kind of a new benefit, they're looking at three things mainly. They're looking at who's eligible to receive that service. So what's the criteria by which someone's going to be receiving that service? what is the benefit? You have to describe what it actually is. And then, how often you're going to provide it, what's the practice, what's the standard for that benefit? And then who's going to be providing the service? Who's the provider of that service? So in thinking about these new services, that is what we were focused on. We were focused on describing who would be eligible for that service. So what's the medical criteria that we were thinking about, what the service itself was. We worked with Papa Ololakahi, and we also worked with a couple of our health plans who also provide these services, so Aloha Care and United Healthcare, both in different settings, different things. They don't provide it exactly like this, but they do have this as a benefit for them, as a added benefit for people who enroll with them. And then we worked really hard to meet with many different people in trying to put this benefit together. During our public comment time period, we've gotten more comments on this, like, oh, you don't have this right, this needs to be described differently. So we are very open to comments in this particular area, and we don't assume that we have it right. And this would be another area that we were looking to pilot before rolling it out statewide, or before rolling it out necessarily with all of the benefits. I'm actually not going to go through each of them, but there's a full range. More likely, we would focus on the ones on the left-hand side first, and then on the 4, 5, and 6 would come later. Some we have to work on some other. We don't have the infrastructure currently in the Medicaid program to support in general, and others, they're more related to healing practices that you might already think about as having, like Lomi Lomi. It's both physiotherapy and therapeutic massage, and so there's some examples where you can point to. It's like, oh, we have something like that in a similar way within our program. Ho'oponopono, interestingly enough, is it's such that interesting intersection of it's here we're describing it as peacemaking, but really it's therapy, group therapy, and if you want to think about it framing it in a Western medicine kind of a way, which it's awkward frame, but nonetheless that's kind of how we're also approaching it. Some people have asked, well, why didn't you put IPONO as an example into the nutrition supports? And we felt like we wanted to keep all the Native Hawaiian traditional healing supports together and have them be considered together, because there's actually so much more to the IPONO than just the nutrition supports aspect of it. And so, but we do realize and recognize that it is combined. We also know, and the other reason is because since CMS has not approved this anywhere, we know that it's going to take a lot more work and a lot more conversation, a lot more negotiations and length of time for us to have this conversation with CMS around these particular benefits. And we didn't want to have one thing put in, like in the nutrition supports, that might slow the approval of those other things down. So that was our logic behind that.
Before we move on, members, any questions or comments on this area? I do have a comment, I think.
Mm-hmm.
Again, on our side of this table, there has been always questions about how can we integrate Lomi Lomi, how can we integrate non-Western practices into our health benefit plan. So I see this as actionable steps to that call to action that we've been, again, saying for many years on this side, so I really appreciate this. I also think that, we have health plans that do support wellness programs, and HULA is, we understand that these all have, as you note in your slide, healing benefits. So
Mm-hmm.
it's for us to communicate to a mainland
Yeah.
federal agency that these things are important. So speaking as a representative of a community that has Hawaiian homelands. We both, Vice Chair and I, both represent Papa Kolea. We have a very active community of Native Hawaiian practitioners who I think will really appreciate this effort. So we will also share this with our community and seek more comments about how to improve this because, and I'll make one last comment. I also think that in the process, does it also help to have federal congressional support for some of our waiver requests?
It will.
Okay, so we will also communicate to our congressional delegation because I know that Senator Schatz, Senator Hirono, Congresswoman Tokuda, and Congressman Case also support these kinds of efforts. So we'll communicate to them what's happening in this 1115 waiver request, and I think we're going to hopefully get some support there too.
I hope so too. I should note that we do have an error on this particular slide that I neglected to correct. On the Hapai Hanau, it should not say Native Hawaiian traditional midwifery practices. It actually should say Native Hawaiian birthing practices. So I apologize for not.
Can we get a
Not correcting
correction
that.
to this slide
Yes.
before we post it to the
We will.
public?
Thank you very
website?
much for that.
Thank you.
I would also note that although there is some conversation around this, some of the providers that we're looking at, we don't want them to have to go through I think our Medicaid providers would describe as administratively burdensome process for becoming a Medicaid provider, getting credentialed with the health plans, et cetera. And so we're actually looking at a different process for identifying them. We're actually looking at the Council of Kapunas, working with Papa Olakahi. We have a lot more conversations because that's one of the aspects that's come out during our conversations about who they are, what they do, et cetera, and which providers, but nonetheless, that is our original intent. And then we're not limiting these Native Hawaiian traditional healing practices to individuals who identify as Native Hawaiian. We know that in our state in particular, there's a broad range of people who like practice hula and et cetera, even though they may not identify necessarily as Native Hawaiian, and who would benefit from the healing practices of the Native Hawaiian traditional healing.
Excuse me. This is not part of the current submittal.
It is.
It is part of our current submittal,
Oh,
but it's proposed. And all the other things that we have put forward that are new to this proposal, we have examples where CMS has approved them in other states.
okay.
And so this is the only one where, yes, we are proposing it, we are including it, but we do not have examples in other states where CMS has approved it. Is that helpful?
Yeah.
Okay. All right. We're actually also looking for some new funding opportunities so that these new funding opportunities allow you to leverage Medicaid funds without having to use necessarily general funds, as an example, for the state fund share of these things. So two things that we're looking at is CMS has newly approved infrastructure funding, which means that, like, if you need a system, an information system, or workforce training, or something like that, which are considered to be infrastructure, kind of more related infrastructure things, then we had some requests in for helping us to support the nutrition supports, health-related social needs, as examples. And then the other one, do I have another slide on this? I do, okay. So the other one, I'm just gonna, I'll cover in just a moment here. But I do wanna note that for one of these, I'm just gonna go to the next page. Okay, so I already talked about the infrastructure funding portion of it. For CMS guidance, you're not allowed to go above a certain amount for the just, focusing on the infrastructure. So our ask will keep it within the caps that they have for health-related social needs, as well as for the infrastructure funding itself cap. And then this other one, it's called Designated State Health Programs. And I will just note here that CMS has changed their policy on this particular funding mechanism a lot over the years. And so, like, for example, the last time that we went in for our waiver renewal, CMS had just come out and said, we will no longer fund, and we're not going to allow other states this particular funding mechanism called Designated State Health Program funding match. In the meantime, new administration, new perspective, and they said, okay, for current states that already have it, they've been renewing these designated state health programs. So they've been doing it, but they haven't approved anybody new. So we don't know what their perspective will be on this. So this is one of those programs that when I explain it, I have to be very, very careful with my words because it's easily misunderstood. So what a designated state health program is it looks around in your state budget and it says, oh, it's for certain state-funded health programs they're not Medicaid, they have no federal match, they have no federal dollar connection, they're not being used for maintenance of effort, nothing, but they're for a program that could be a Medicaid program. It just so happens that you're using state funds for it. And what CMS says is that, okay, we will allow you, we will match this program. We'll give you the federal match for that program, and you can take the freed up general fund and spend it in Medicaid. So not in that other program. We're just gonna match that so you have some additional dollars, additional state fund dollars that now you can spend for your state fund share for some of these programs. Many, many strings attached to this particular program. I happen to be, I'm the former Medicaid director in Oregon. I happen to be in Oregon when the designated state health programs was developed in Oregon, so I can speak to the complicated nature of it and the difficulties of putting it together. But nonetheless, it can be a valuable source. Instead of spending, you don't have to come up with new dollars in order to support some of these many activities that we're proposing to do. You don't have to come up with new ones in that you can use these already existing expenditures and then they'll give you the federal match for it, freeing up the state fund share.
So $30 million thereabouts?
It could go up to about that right now.
Thanks.
Okay, so not too late to submit written comments. So we have until November 16th, which is 10 days from now. And there's the email address. You can mail the comments to us. You can click on here and you can find the full document, and it's extensive, right? And you can also find our former presentations, recordings of the public hearings as well. And if you need anything in special accommodations, you can also call or email us. Oh, that date's already, I missed that date, sorry. November 7th, oh, that's tomorrow, but, so, not too late. So, okay. Wow, 11 o'clock. Yeah.
Okay, can we make sure that this slide stays up for the public? I think this is a
Okay.
really important place to end. And that's the conclusion of your presentation?
Yes, it is.
So we've been doing questions and answers and comments as we've gone along, but I want to give one more opportunity for any questions or comments.
Online?
I don't believe there's any questions or comments online from our representatives there. I guess I do have a couple of comments or questions first, and they're very just technical questions, and that's why this slide I would like to keep up. When will the final draft be submitted approximately to CMS?
It will be submitted no later than February 1. Internally, we have a target date of December because we would like to give ourselves some additional time for a negotiation.
So this opportunity for the public to weigh in, November 16th, is still open. We have 10 more days of that, and I think if anyone has been listening and watching and is interested in supporting these areas, I know you can ask for support, you can just ask for comments, but I think there's much here that is advancing the priorities of the people of the state of Hawaii. So I would put the call out to action to all of our community partners out there, and who may not traditionally think of themselves as part of the Medicaid ecosystem. You know, we have folks in the agricultural industry, we have folks in the homeless service providers industry, we have folks in our Native Hawaiian communities who would greatly benefit from all of the things that we talked about today. So I urge the public to look at this November 16th deadline. I have a question and to submit comments to you folks first. Moving on, you mentioned that there's going to be a federal comment period.
That's
Is that also a period in which the public can comment on the final draft that you submit?
It is. Thank you very much for asking that. Once we turn it into CMS, CMS does a quick evaluation. Hey, is this application complete? If it is, then they post out on their website that Hawaii's 1115 demonstration is open for public comment. It is actually also a 30-day public comment time period, and anybody can submit comments, including anybody from Hawaii across the country. Well, actually, anybody from across the country can submit comments now, but then they can submit them to CMS.
Okay, I really would urge you to keep our committee apprised of when this happens, because this is a critical policy step that I think we can all get engaged in, individuals in the public, organizations in the public, and us as an
We'll be happy to
organization.
forward you. They usually post it, and then they send us the posting as well, with a link on how to get to the whole application and then et cetera. And we'll be sure to forward that to you.
I probably have more questions, but I think this is a great start, and that's what these informational briefings are. This really is an opportunity to educate the community. I'm going to exercise a little bit of my discretion now, and I see someone in the audience. So members, if you indulge me, I see Kat Brady, who works with the Community Alliance Prisons. I know Kat Brady participated in the community briefings. Kat, would you like to come up and say any comments from your perspective on this demonstration renewal application? And yes, if you could just speak at that. Or no, actually, if you could come to the desk. Meredith, if you could allow.
No, this is fun.
No, we need to have you sit. And so to members of the public, these informational briefings are open. Typically, we don't just call people up, but I am exercising my discretion. We want the public involved in these informational briefings, so
Yes.
thank you for being here in person. I just wanted to see if you had any comments on this, on any parts of this application process from your perspective as a community member.
Well, I'm just really, really thankful to Judy and her team, because this application was 520 pages. It was huge, and she managed to break it down into something understandable. And I got a lot of comments after the community hearings in Kapolei and in Honolulu, people saying, wow, we get it. This is really cool. So this is really groundbreaking, and we are so grateful for Judy's experience, because she actually looked at California and Washington and went with the broader one. And we're really, really happy about that, because many, many people are released from prison with nothing. No medication, no ID, no money. So this is really, really helpful. And I've been working with service providers who have all told me, oh, the 30-day medication, so crucial.
So from your perspective, you think that the community is primed and ready to kind of help begin to partner and implement these services should we get the federal waiver granted to us?
Yes, I believe that the community is really ready to go. This is a long time coming, and we never ever agreed with inmate exclusion. we think healthcare is for everyone.
All right. Thank you for letting me put you on the spot. And thank you, Dr. Peterson, Dr. Starr, Ms. Nichols. I'll let you leave with any last closing comments, Dr. Peterson, and then we will adjourn.
Thank you so much. I really very much appreciate this opportunity. Thank you very much for allowing us to spend this time to talk about these initiatives. We're very excited. We're excited about the community outreach that we already have, but this is really only the start, right? And that the hard work is, once you get it, then implementing it. As we already have some lessons learned from our community education services, when you move into an area that's brand new like this, when the healthcare system is working together with other areas, it can be a bit of an awkward start and challenging. But we know that we're starting with a good foundation. We're really excited about the work, and hopeful that we'll be able to keep going.
All right. Thank you, Dr. Peterson, Dr. Starr, Ms. Nichols. This informational briefing on the Committee on Health and Homelessness is now adjourned.